this day and age, and you might get 10 minutes with them, but you may have more questions. And so my hope is that what you'll get out of from today's talk is basically a basic understanding of treatment and diagnosis for hip and knee arthritis. And then if you have those types of issues, you can have kind of the next level conversation and really just feel confident that all your questions are answered when you see your doctor. So we're going to talk about hip and knee replacement today, and the talk is called Home Sweet Home because more and more of our patients are going home the same day of surgery. So we'll jump right into it. I'll do the hip first, then I'll do the knee, and then we'll go through questions. So just write those in the chat, and we'll go from there. So this is a picture of an arthritic hip. This bone has a cyst in it. These bones are touching right here. So that's something that might need a hip replacement at some point. But let's start with the basics, the anatomy. The hip is a ball and socket joint. So you have a ball that's actually the top part of your femur or thigh bone that sits in a socket that's your pelvis. And so that ball is covered in articular cartilage, as is the surface of the pelvis right here. So a natural healthy hip has cartilage rubbing on cartilage, which is a good thing. One of the most common problems with hips is arthritis. It's a wear and tear condition that degenerates the joint. It usually doesn't get better, and it definitely can get worse. Rheumatoid arthritis is another reason people develop arthritis, and that's an autoimmune disease that attacks the lining of the joints, but ends up with the same problem where you have a degenerative joint. So how do you develop arthritis in the hip? Well, you could have abnormal anatomy. Maybe you were born with an abnormal hip socket as a kid or as an infant. You can have abnormal biology. Maybe the blood flow to the top part of the femur, the femoral head, is bad, and you develop a condition known as avascular necrosis, which Bo Jackson got. So Bo knows AVN. Overuse, just a lifetime of activity. And then genetics is probably the biggest one, in my opinion. So many people will be told they have a diagnosis of hip arthritis, and they'll say, oh, my mom had 2 hip replacements. My brother had a hip replacement last year. So not uncommon for it to be common amongst family members. So again, the end of each bone is covered with cartilage, and the cartilage rubs on cartilage, and that's a nice cushion, so the joint functions without pain. In a diseased or worn out hip, the wear and tear deteriorates that natural cushion of cartilage, and then you end up with bone on bone contact. That leads to soreness, stiffness, swelling, pain, all the symptoms of arthritis. So I liken it to a door hinge. Here's a normal functioning joint at Capital Health Hopewell, which even though I think it's like 13 years old now, it still feels brand new. It's healthy cartilage. It's well lubricated. It has full motion. It's pain-free, doesn't creak or cracks. And then, you take normal functions for granted, getting in and out of a car, exercising, sleeping, just enjoying life. Well, here's what happens. Here's your arthritic joint. This is a rusty old door hinge, right? There's damage to the cartilage. There's loss of the lubricating mechanism. It doesn't open all the way, so it's lost range of motion. It creaks, it cracks, it's painful. And that's my best analogy for what an arthritic joint is like. So when we talk to our hip replacement or hip arthritis patients, we ask them, do you limp? Is it hard to perform like regular tasks? The most common people will complain about is tying shoes or putting on socks or shoes. Does the pain limit activity or lifestyle? Does one leg feel shorter? Do you have balance issues? Where do you have pain? Is it in the groin, the thigh, the butt? Does it radiate down to the knee? These are all common complaints of people with hip arthritis. So, not every treatment in orthopedics needs surgery. So just because you have hip arthritis doesn't mean you need surgery. You can manage that without surgery. Water therapy, like soaking in hot packs or ice packs, getting in a pool and moving, exercise and physical therapy are really good, especially an exercise bike, and are good for weight loss as well. Medications like anti-inflammatories, injections like steroids can all help with pain. But at the end of the day, the hip arthritis will eventually not respond to the conservative treatment measures. And that's when a hip replacement is a reasonable option. Basically, it's a surgery where we replace those damaged surfaces, relieves pain and improves mobility, and it's pretty common in our country. This number's from 2009. It's probably double that by now. So what is a hip replacement? Well, let's go back to the beginning. Here's the initial picture that we had, right? This ball on top of the femur, that's the socket on the pelvis. Well, here, it's the same exact thing. There's a ball sitting on top of the femur, and it's sitting in a socket in the pelvis. So basically, in a hip replacement, we put a metal stem inside of your femoral canal and inside the femur bone. A metal shell sits in the pelvis here, and then a ball and our liner complete the articulation. So we really try to truly recreate your anatomy. So here's another x-ray. Here's an arthritic hip. This is bone on bone right here. There's cysts in the femur, this and this. those are all signs of arthritis. And here's the replaced hip. Here's the metal shell in the pelvis. Here's the metal stem in the femur, and here's the ball sitting on the femur and sitting in the socket. That's what a hip replacement looks like. So the anterior approach is not really new anymore, but it's a way to get into the hip joint from the front, whereas most hip arthroplasty incisions are on the side or the back of the body. And we do this at Capital Health. We've been doing it for over a decade now. In a traditional surgery, patients are going to be lying on their side, and the surgeon will get to the hip by going through muscle or tendon. In an anterior approach, we actually use this torture device here at Capital Health. And basically what we can do is we can manipulate the leg in surgery so that we can access the hip joint without cutting any muscle. And we hope and think that leads to a faster recovery. Studies show that by about 4 to 6 weeks, everybody's the same, regardless of the approach. But this is a nice way to do surgery, and this is my preferred method. Additionally, I can get an X-ray intraoperatively to check component position before taking the patient out of the operating room. Overall, hip replacement is a wildly successful surgery. It was dubbed the surgery of the century, last century. More than 96% of people say it enabled them to move freely and without pain, and they're very satisfied with the surgery, and they would do it again. They would do it again. So a very, very successful procedure that can really, truly change one's quality of life, and that's why we do it. We really get a lot of benefit and gratitude when we see that our patients are very happy after their surgeries. So in summary, the leading cause of hip pain is arthritis. It's a degenerative condition that won't get better and will likely get worse as you get older. Early diagnosis and the use of non-operative treatments are important. Hip replacement is a great procedure to help relieve pain and improve mobility. And your surgeon can choose the right approach and implant and facility for you. Moving on to the knee. The knee is a pretty complex joint, even though people think, oh, it looks just like a hinge. But you have cartilage between the femur, the thigh bone, and the tibia, the shin bone here. There's also the patella, the kneecap. So there the bones are labeled. And it's the largest joint in the body. And it actually moves, it doesn't just straighten and bend, it moves in multiple degrees as it goes through a range of motion. And everybody's actually a little different. So that's why it's a little harder to, a little more complex than people think. So again, knee arthritis is one of the most common complaints. 70 million people in the US have some form of arthritis. Again, arthritis is that wear and tear that deteriorates that cushion, that cartilage in your joints. Again, knee replacement or knee arthritis patients can have regular osteoarthritis or rheumatoid arthritis. So again, what's causing your knee pain? The healthy end of the bone is covered with cartilage, which is the cushion. Arthritis is the wear and tear or breakdown of that cushion. So here's a cartoon with the white stuff here is cartilage, and then where it's kind of not white or it's reddish or brownish, that's exposed bone. That's where the cartilage is damaged, okay? Here's an X-ray with some black space between the two bones, the femur here and the tibia here. That's good. Here's an X-ray where there's no space. You see the femur and tibia are touching. That's severe arthritis right there. So we ask our knee arthritis patients, does your knee hurt more than one day a week? Does it interfere with sleep? Is it difficult to walk? Are you gaining weight from inactivity? These are all reasons to consider knee replacement. Again, how can we treat? Principles are pretty much the same as the hip. There's water therapy like the pool or ice or hot packs. There's medications, anti-inflammatories, steroids, and steroid injections. Exercise, physical therapy, believe it or not, are good for an arthritic joint and also good for weight loss. I think low impact exercise is better. So I recommend for my knee arthritis patients, a swimming pool or an exercise bike. Injections are also helpful. And here's one place where the knee differs from the hip. There's another injection called viscosupplementation or hyaluronic acid. It's got a million names out there like chicken egg, rooster comb, Synvisc, Orthovisc. They're all the same stuff. Basically, they are injections that go into the knee that are synthetic joint fluid. They can act to decrease inflammation and help with lubrication in the knee joint. Eventually, though, these non-operative treatments fail to provide long-lasting or effective relief, and a knee replacement's in order. It's a great surgery that helps replace damaged surfaces, helps relieve pain and restore mobility. Very common. We're probably close to 1 million in the United States every year. And so what does it look like? Well, here's an example. So here's a fake bone, and here's a fake bone. This is the femur. Here's the femoral component sitting on the end of the femur, tibial component sitting on top of the tibia. So this is really more of a resurfacing than a replacement because we're keeping almost all of your bone. We're just removing enough bone in surgery to fix this implant onto the end of the bone, which is usually about 1 centimeter or less thick. Here's an X-ray with a metal femur, a metal tibia, and then this piece of plastic in between doesn't show up on x-ray, so it's just black. And that's kind of analogous to your cartilage. So again, a healthy knee here, we have space between the bones, and then here's what a knee replacement looks like: a metal femur, metal tibia, space between the bones. That space that space here on this image is a piece of plastic. The space here on this image is actually cartilage. So in summary, the leading cause of knee pain is arthritis, which is a degenerative condition that won't get better and will probably get worse. Early diagnosis and treatment are important because you can improve your function and pain levels with those. And knee replacement is a very popular and very successful surgery. So what can you expect? These are the questions that really we talk about in the office with patients: the hospital stay, the recovery, the pain control, the nausea control, the therapy, the return to work. So, hospital stay, we're going to talk a little very shortly that, you can actually not stay in a hospital. You can go home the same day. Recovery, that's a mixed bag. It means something different to everybody. And so we'll talk a little bit about that. Pain control, very important after the surgery. If your pain's not controlled, you can't participate in physical therapy. And that's what you need to do. Usually within a few hours of surgery, you need to get up and walk that day. Nausea control, again, just like pain. If you're throwing up and vomiting, you're not going to be able to walk with therapy the day of surgery. So we have to keep that under control. Physical therapy, extremely important in success after knee replacement. And that doesn't necessarily mean you're going to your therapist. That means that, you're doing it on your own, because you might go to a therapist 3 times a week, or they might come to your house once a week for 30 minutes. But you, the patient, has to do the therapy every day. And that's really the key to success. And then return to work is kind of a mixed bag as well. If you're, have a desk job, you can get back to work relatively quickly. This day and age, at post-COVID, people can work remotely so often. You can get back to work relatively quickly. I still think this is a big deal, and you really need to give your body time to recover. There's a lot of stiffness and soreness and swelling after knee replacement surgery, so it's important to really focus on the knee, ice, elevate, things like that. And that may preclude you from going back to work for a few weeks. If you're a laborer, construction worker, warehouse worker, you're looking at 3 months before you can reliably get back to work. So outpatient joint replacement, why, what is it? It's basically what it says. It's going home the same day from surgery. Why is it more common now? A couple of reasons. Number one is insurance. Medicare allows it and frankly encourages it because it costs them less. And all the other insurance companies follow suit there. Additionally, during COVID, once we were allowed to do surgery again, one of the stipulations was the patients had to leave. So we really developed some of these protocols out of necessity, and now people have done so well with it and people are happy with it that it's become more common. And you have to talk to your doctor to see if you're a candidate to go home the same day, but typically patients who have a lot of medical problems or are complex, we want to stay in the hospital. But if you're 70 years old and you're on one medication, you could probably go home the same day. So the big key here is safety. We really want, if patients are going to go home the same day, or even if they go home the day after or 2 days after surgery, we want it to be safe. So we want to select healthy patients to go home the same day of surgery. We want to do all the same infection prevention things that we do for the patients who stay overnight in the hospital. So we're talking the wipes that people do before surgery. We're talking nasal swabs, and same protocols again for room and instrument cleaning. Basically, just because you're going home after the knee replacement doesn't mean there's anything different in your surgery or care from the patient who's staying overnight. Patient education. Patient also has to have expectations. They have to be prepared. Hey, there's going to be pain at some point. We use nerve blocks for pain, but when that wears off, there will be pain. It will be difficult to move. And so mentally, a patient has to be prepared. It's always helpful to have a caregiver or a coach. Usually that ends up being a spouse or a child. And the goal I have for patients when we sign up for surgery is that when they show up in the morning of surgery, they have no questions. They've already gone through everything. The educational materials I've given them to prepare for surgery have answered all their questions, and that's the goal. The big thing for patients with any type of surgery, but especially with knee replacement, is going to be the fear of unknown and the fear of pain. There's concern that they're going to be in pain, and that's very scary for all of us. There's concern that you might be dependent upon others. There's concern you might not be able to be independent and drive. What about getting back to work? When will I feel normal? So these are all natural concerns. And the answer is different for everybody. Not every patient follows a specific timeline or guideline after surgery. So with outpatient joint replacement, one of the keys I mentioned before is pain management. So we actually do pain or analgesia. We actually do pain management or analgesia before, during, and after surgery. So patients take medications before surgery. They get injections and nerve blocks in surgery. And then after surgery, they also get pill or oral medications. We really try to limit the narcotics. And by doing different medicines like anti-inflammatories, like a celecoxib, like Tylenol, or a meloxicam, gabapentin's another drug we can use. By using all these different drugs, we can decrease the amount of narcotics or opioids patients take, which is really important given the opioid epidemic we have right now. Additionally, very important that we work with our therapists. I think for knees, especially preoperative physical therapy is very important. What about medical equipment? Getting a walker or a commode or something to help you put socks on, or an ice machine. Good to plan ahead and get those things ahead of time. When patients do go home the day of surgery, the physical therapist at Capitol Health will actually come see them in the recovery area quite often. And one thing people always ask about, what about steps? Can I go up and down steps? Steps are encouraged after surgery. That's part of your therapy. You may not be able to do it as much the day 1 versus day 28, but our facility actually has practice stairs for you to work on before we send you home. So the therapist really makes sure you're set before you go home. So, people also always ask, how can I prevent a joint replacement? Number one way is to stay active with an exercise program. And number two is to do weight control. There are studies out of England where they follow people for 40 or 50 years. People who were just 10 pounds overweight in their 20s actually had about a 3 times higher rate of knee replacement in their 50s. So weight control is really important. So that was most of what I had for you today. I figured I could take some questions now. So what I'll do is I'll open the chat and give me 1 second here. Oh. Are there any options that will resurface the bone with a cushion before joint replacement? No, there are not. That has not been invented yet. So yeah, joint replacement is really the only way to resurface the bone with cushion. For younger patients with isolated cartilage defects, we're talking really small, like 1 centimeter or 2 centimeter. There are bone grafts and things, cartilage grafts they can do. But when we're talking over 50 years old with cartilage damage, there really aren't other surgical options that are effective. Let's see. Can I expect normal healing of hip replacement if I have osteopenia of the femur head? Well, if you have osteopenia of the femoral head, it'll actually be cut out. So that really shouldn't affect your hip replacement. What could affect it, though, is if you have osteopenia or osteoporosis in the other parts of the bone. We actually expect a lot of our patients to have weakened bone. And so it doesn't really change what we do. So it's not really, it doesn't really affect what we do, but it certainly is of concern. So I think bone health is very important. The person who asked that question said they're not currently treated. Well, it's important to get the diagnosis, get the DEXA scan. If you're going to treat it, whether it's with supplements, whether it's medications, there's pluses and minuses to all of those things. So while it doesn't change, whether or not you can have a hip or knee replacement, it's still an important thing to address for bone health. One of the trends I'm seeing in menopause is having gluteal tendinopathy. That's a symptom of stiffness when moving in the morning or after sitting for a long time. Do you see this in your practice, and what are your thoughts on dealing with this? So gluteal tendinopathy is really kind of a spectrum of conditions that kind of, in my opinion, fall under trochanteric bursitis, which is soft tissue inflammation. Soft tissue inflammation is not related to hip arthritis. It can certainly cause pain, and there are non-operative treatments to help with this type of issue. The mainstay are anti-inflammatories, injections, and physical therapy. For patients who don't get better with those, there are surgical treatments, which are probably beyond the scope of this talk because I don't do them. But there are options out there. And does having bursitis or gluteal tendinopathy lead to a hip replacement down the road? I don't believe it does. There may be some abnormal mechanics in the joint around the joint there, but ultimately, I don't think tendinopathy really affects cartilage, so I don't think it does. Maggie put a survey in the chat. Please, if you guys could fill that out, that's really helpful, not only for feedback for me, but also for Capitol Health. What lectures, what topics does the community want to hear about? So that's really important.
Dr. Saxena, we had one other question of what causes the hip popping sound?
It's a good question. People often ask, I get popping in my joints. What is that? To be honest, I don't have an exact answer for you. I can tell you that when I squat down really low on my knees, I hear a pop. And so it may be something to do with gas inside the joint. I've heard before people talk about like nitrogen gas in there, but it's not a bad thing. So popping in the joint isn't a bad thing. If it hurts, then it's something that you might want to treat for pain, but the actual popping isn't necessarily a bad thing. Someone asked about hip flexor issues. Is that a typical side issue of hip arthritis? Yes and no. You can have a hip flexor issue with like tendonitis or bursitis, something like that, which is unrelated to hip arthritis. But you can also have hip flexor issues because of the arthritis. If the arthritis leaves you with limited range of motion, that can ultimately affect your hip flexors as well. So it may or may not affect or be associated with hip arthritis. Do knee replacements have a life expectancy? And the question is, can you be too young to be a candidate? They do. We have good data that shows hip and knee replacements last for 20 years, 80 to 90% of the time. So in theory, if you're 35 years old and you have a bad hip, or a bad knee, which isn't common, you could end up having a surgery and then needing another surgery in your 50s. And then when that fails, needing another surgery in your 60s or 70s or 80s and so on. So that is a concern, but this is a quality of life surgery. So if you have a horrible quality of life with a severely arthritic hip or knee, I don't really think you're ever too young for it. You just have to go in knowing the options and the potential consequences. I've had 3 cortisone injections. They didn't provide relief. Had gel injections, no relief. MRI revealed replacements not needed by Rothman. What would you suggest next? He wants me to see a rheumatologist. Actually, that's exactly where I would go with that. Without seeing your X-ray or examining you, I think a rheumatologist would be a good next step for you. Do you recommend PRP? PRP, also known as platelet-rich plasma. It's a procedure in which they take blood out of your body and spin it out so the liquid's gone, and they take the platelet infused plasma and they can inject it wherever they want. It hasn't really been proven to be an effective or a better treatment than the treatments we have for knee arthritis. It's certainly not going to prevent you from needing a knee replacement, but it is an option that can decrease pain for someone with arthritis. So it's something you can consider trying. Again, based on the fact that there isn't much evidence out there, it's not covered by insurance, so it's usually a cash procedure. The regret people always have is if they do it and they didn't get better, it's like, well, then they threw that money down the drain. So it's a little bit of a tough situation there. But to be clear, PRP is not going to remove the need for eventual knee replacement. It just may decrease inflammation and help with pain, just like a steroid or a gel injection would. Someone has a torn meniscus, is knee replacement an option? Typically, no. If you have a torn meniscus with normal cartilage, then definitely no. If you have a torn meniscus but you have bad arthritis, it could be. So it would depend on the situation and how bad your arthritis is. Can building one's leg muscles reduce wear or tear on the knee? Absolutely, it can. By building up the leg muscles, you can offload the forces that go through the knee and decrease wear and tear. So a leg workout, even if you don't have knee arthritis, is a good thing. It can absolutely help your muscles and your joints. Can 2 knees be done at the same time? They certainly can. I don't advise it. I think it's really hard for people to recover. And there's also more risk associated with blood loss and pulmonary issues. So I don't really recommend 2 knees or 2 hips at the same time, though it can be done. How often does a patient end up with a longer leg from the surgery? Well, in knee arthritis, it's not really common at all. In hip arthritis, the hope is not too often. Our goal in hip arthritis is, as I said before, was to recreate the patient's normal anatomy. So we don't want to make your leg significantly longer or shorter than it is before surgery. So the goal is to not have that happen. I've been diagnosed with jumper's knee in the right knee. That's basically tendonitis. 51 years old, 5'10" and weigh between 105 and 185, 190. Done PT with good results. Is your specialty strictly for knee replacement, or would you suggest additional PT? No, I mean, I treat knees in general. I only pretty much operate on knee arthritis, so I mostly do knee replacement. But yeah, if you've had good results with PT, I think you'd keep wanting to keep doing that for tendonitis of the knee. Additionally, at 5'10", 185, if you could get down to 175, that might take some force off the knee, so that might help as well. Pretty active, strengthening quads and hips, but pain seems to be taking slower than expected. Yeah, and sometimes tendonitis can be really annoying. Plantar fasciitis is another condition that can take 6-12 months to really feel all the way better. So usually it's just a question of continuing to do exercises, taking anti-inflammatories as needed. Question about stem cells. Any success there? Not a ton. The goal with stem cells is that they one day fix all the problems in our bodies, and we are just not there yet with science. There's no good data to show that they are effective treatments for knee arthritis. There's certainly no good data to show that they will reverse arthritis and just basically cure it. The hope is one day that's out there, but that is not today. So again, it comes back to the same thing with the PRP injections. Like, you could pay cash for it. Stem cells are usually more expensive, probably like 10,000 each. And then if you get it and you don't get better, that kind of stinks. Question about a Baker's cyst. A Baker's cyst is a fluid-filled cavity in the back of your knee that usually occurs when you have like a meniscus tear or arthritis. The best treatment for a Baker's cyst is to cure the problem that's in the knee, and usually the cyst will go away. Oftentimes, people want their Baker's cyst aspirated or have the fluid removed. Usually, it just comes back, so it's not that helpful to do that. As far as surgically removing a Baker's cyst, your artery, nerve, and vein that supply the entire lower leg are right there. So that's not a surgery we commonly do because we're trying to avoid any type of surgery in that area. The patient's bodies have rejected materials using the replacements. It's somewhat of a controversial question if that rejection exists or not, but there could be some allergies to metal or cement or even plastic that would cause a rejection of the implant. So it's not common. It's not necessarily clearly defined, but it's something that in theory can happen. Those were all really good questions. Let me see if I missed any. Question about how do you determine what materials to use for the knee replacement? There's a bunch of different implants out there, but they're basically all the same. So it's like Ford or Chevy. Basically most surgeons just use something they're comfortable with or they've trained with, and that's usually how we determine it.
I have a question.
I have a question.
I'm 91 and I have a knee replacement, and I had one in 2011, and now it has what I think is arthritis and causes me pain. What can I do for that? What kind of medications are there?
So you can take anti-inflammatories, but by definition, the fact that you have a knee replacement, it means, there probably isn't arthritis that's causing your pain. So it might be a good idea to get an x-ray of the implant to see if anything is going on with the implant. Could the plastic be wearing out? Could the metal components be getting loose from your femur or tibia? So that's probably your next step would be to get an x-ray.
Thank you.
I think someone named Naomi had a question.
I do have a question. So I've been having a lot of pain in my hip area, particularly in the joints and the inner thigh and the outer side of my leg. And I had a x-ray last week, and my primary care called me and said it shows moderate arthritis, which I knew I had, but she doesn't think that is what's causing me the issues that I'm having. So my question is, what is my next step? Should I be seeing an orthopedic person?
Yeah,
a
it sounds like there's a phone
rheumatologist?
number on your screen, and that's what you need to do. You need to see an orthopedist, and then there's ways we can figure out, is the pain coming from your hip or not? We can do physical exam tests to figure that out. We can do injections to try to figure that out. So yeah, that sounds like that's your next step.
Yeah, and I actually live outside the country, so I do come to New Jersey, and I'm seeing at this this facility here, but it's just been really difficult at times to walk. I feel like when I do anti-inflammatory, it really helps. So
Good.
I feel as if I'm probably having a lot of inflammation issues. And the reason I'm saying that, because at the same time, then my heels will be hurting around the same time I'm having this flare up, as well as I will have a lot of like mucus in my throat in the mornings when I wake up, this continuous mucus. So I feel like it's related to some inflammatory situation.
So then, it sounds like you really need a rheumatologist. So that's actually with pain in multiple joints, things like that, you need a rheumatologist. That's probably your next step.
And now my knee's hurting, and I'm thinking it's maybe because I'm putting the pressure a particular place because of the situation with my hip. So
maybe you just need a rheumatologist.
Okay, so thank you. I was trying to figure out which way I should go, whether rheumatologists or, so thank you for that information. And I was so happy to receive this information. I swear, AI really knows what's happening. They're listening, because when they showed up in my my text message, I was like, what? So
great.
It's just
All right,
what I needed.
We'll move on to some other people's questions now. Thanks.
Thank you. Thank you.
So leg pain seems to come from the hip. What's the best treatment? If you're having leg pain, it can radiate down from the hip joint. It could also come from your back. So I think before we try to treat things, the best thing to do is really diagnose them. So you probably need an x-ray or at least a physical exam to say, is the pain coming from the hip or the back, and then kind of go from there. Someone asked about the gel injections. Basically, the gel injection it's a synthetic joint fluid you inject into the knee. It decreases inflammation and lubricates the joint. It's a very simple, quick procedure like any other steroid injection that can be done in the office. You don't need an ultrasound or imaging or anything like that. We do tons of those every year at Rothman, probably in the orders of tens, maybe even hundreds of thousands. If an x-ray shows arthritis of the hip, is an MRI a good next step, or does x-ray give enough info? Yeah, typically for knee and hip arthritis, an x-ray is all we need. Sometimes we can get an MRI if there's some questions about some other issues, but really an x-ray is all you need to diagnose arthritis. We do have an office in Hamilton, New Jersey. And someone said they've been experiencing sharp pain in their heel. You could see a podiatrist or a foot and ankle surgeon, and we have a number of them at Rothman, so you can certainly give us a call. Someone asked about a gluten-free diet. There is a whole theory, a whole clinic out there about the diet and how it affects pain and how it affects inflammation. I'm going to type it in the chat. One of my partners, Dr. Salani Sharma, actually has a book on this about a diet that fights inflammation. You can look it up on Amazon. So that's a really interesting, she has a lot of really interesting information there about that, about how a lot of the things in our diet, especially the American diet, the processed sugars, things like that, are not good for our bodies and create more inflammation. I think someone had asked too about the VIP line. I think the VIP line is a good way to call Rothman. We have so many people calling every day that sometimes you might get put on hold. The VIP line is a faster way to get to our team to figure out who you might need to see or where or when you could see them. Additionally, you even have the option of kind of keeping your place in the queue and then hanging up and having somebody call you. So we'd be happy to help you at Rothman. And we work with Capital Health very closely. We do a lot of surgeries there, and it's a great facility and a great system. So, well, thank you very much. Again, all great questions. I hope you guys got something out of this, and you'll be able to take, your questions a step higher whenever you do seek treatment. Take care, everybody.
Thank you very much. And as Dr. Saxena said, please do the evaluation at the end. And also there's the link for the video recording.